You can start.
Good morning, everyone.
Start the timer also, please.
Good morning, everyone. I'm here to present on study of retinal nerve fiber layer thickness in patients with type 2 diabetes mellitus. Diabetic retinopathy, as you know, is an important cause of preventable blindness. Many studies have demonstrated that neurodegenerative changes occur much earlier than microvascular abnormalities. Changes in RNFL thickness in patients with diabetes mellitus type 2 have been studied, but the results remain controversial. The aim and objective of the study was to assess the retinal nerve fiber layer thickness in patients with type 2 diabetes mellitus. To assess the correlation of RNFL thickness and duration of diabetes mellitus and HbA1c levels. Material and methods. The prospective study was conducted in the outpatient department of CMC Ludhiana. 200 patients were divided into 3 groups. Group A included 50 patients with type 2 DM without diabetic retinopathy. Group B included 50 patients with diabetes mellitus with mild and moderate NPDR, and Group C with 100 age and gender matched non-diabetic controls. The criteria for diagnosis, the inclusion criteria basically was based on the American Diabetes Association, which was HbA1c more than or equal to 6.5%, fasting blood sugar more than or equal to 126, 2-hour plasma glucose more than 200. In a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, self-reported use of diabetic medication, and physician-diagnosed diabetes. Exclusion was based on the patients with history of type 1 DM, diabetic macular edema, severe NPDR or PDR, intraocular inflammation, previous glaucoma, visual field defects, pregnant or nursing females, those who are unable to provide informed consent and complete examination. So this was a performer, the informed consent, detailed history, IOP measurement, anterior segment examination, fundus examination, and screening of visual field. So basically the study was done with the help of spectral domain NIDEC, spectral domain OCT NIDEC RS300. So as you can see, the aiming circle was adjusted over to the center with T-SNET and compared to the global measurements. So the color white, green, yellow, red signified A more than 95, 5 to 95, 1 to 5%, and less than 1%. The result and analysis, basically the distribution of subjects in different age groups. There was no statistical significance between the 3 groups with regards to the age. So this is basically there was no statistical significance difference between the mean ages of the 3 groups here, and in this there was no significance found among the groups regarding gender distribution. So as you can see, the male and female distribution in diabetic without retinopathy, with retinopathy, and the non-diabetics. So here there's a relation with the duration of diabetes and HbA1c. The mean duration of diabetes mellitus in group A was 8.5 with a standard deviation of 6.6, while in group B it was 12.6 with a standard deviation of 7.4. The difference between the 2 groups was statistically significant. Similarly, the mean HbA1c in group A was 8.5 with a standard deviation of 2.1, while group B it was 9.3 with a standard deviation of 2. There was statistical significant difference between the 2 groups. So the comparison of RNFL thickness between diabetics and non-diabetics. Thickness of RNFL was less among the diabetics than non-diabetics for the whole of optic disc, as well as for every quadrant except the nasal quadrant, where RNFL was thicker among diabetics than non-diabetics. The difference in the thickness of the RNFL was statistically significant only in the inferior quadrant, and difference was not statistically significant in the other quadrants. So the comparison of RNFL thickness between diabetics with retinopathy and without retinopathy in the thickness of RNFL for the whole of optic disc and in the temporal quadrant was more among diabetics with retinopathy than diabetics without retinopathy. And the difference in the RNFL thickness with and without diabetic retinopathy was statistically significant. A negative correlation was seen between the RNFL thickness and duration of diabetes mellitus for the whole of optic disc and all the quadrants of optic disc, but this correlation was not statistically significant. So the correlation between RNFL thickness and HbA1c, a positive correlation was seen between RNFL thickness and HbA1c for the whole of the optic disc and all the quadrants of the optic disc, but this correlation was not statistically significant. In conclusion, the RNFL thickness for the whole of optic disc was thinner in diabetics as compared to non-diabetics. RNFL thickness for the whole of optic disc was thicker in diabetics with retinopathy as compared to diabetics without retinopathy, and was statistically not significant. RNFL thickness and duration of diabetes mellitus showed a weak negative correlation. However, this was not statistically significant. RNFL thickness levels of HbA1c showed poor positive and was not statistically significant. Thank you.
Yeah. Just two questions. What is the reason of thinning of RNFL layer in diabetes?
Sir, this could be, sir, possibly due to the leakage of the exudates, and this causes the weakening of the RNFL layer, sir.
That will cause increase in the thickness.
In the
Fluid
diabetic
leakage,
retinopathy, yes,
yeah,
sir.
fluid leakage. But you showed that in patients with retinopathy, RNFL was thinner.
Yes, sir.
So it should be leakage will cause thicker RNFL.
In the diabetic retinopathy, it was thicker, sir.
I think just come to the slide of the conclusion slide. Conclusion before that. Yeah. RNFL thickness for whole of the optic disc was thinner in diabetics with retinopathy as without it, but this difference was not statistically significant. Okay. And what is the practical implication of your study?
Sir,
Okay.
Go in. Thank you. Next.
Gulal.
Next is Dr. Navreet Kaur is there. Dr. Priya.
Good morning, everyone. Today the topic of my presentation is to assess the awareness and knowledge about glaucoma in patients attending OPD of a tertiary care hospital. Glaucoma is the leading cause of vision-related morbidity worldwide.
Wait, Dr. Priya. It is not displayed over here.
One of you stay. एक यहाँ पे रुको यार.
ट्रायल नहीं किया था क्या? Start.
Glaucoma is the leading cause of vision-related morbidity worldwide and the second leading cause of blindness in the world, accounting for up to 8% of total blindness. In India, glaucoma is the leading cause of irreversible blindness with at least 12 million affected people and nearly 1.2 million people blind from the disease. Glaucoma is an optic neuropathy of multi-factor etiology wherein intraocular pressure is the most important and only modifiable risk factor. It usually has no symptoms and the vision stays normal in its early stages. As the optic nerve damage starts, peripheral vision is lost progressively till only the central vision is left, resulting in tunnel vision, total optic nerve atrophy and reversible blindness. There's no cure for glaucoma, but early diagnosis followed by early treatment can often stop or minimize the damage and protect the vision. Early manifest glaucoma trial, it was seen that patients with early and newly diagnosed glaucoma had reduced and delayed glaucoma progression over 6 years from 62% in the untreated group to 45% in the treated group. Alongside, health education and preventive eye care can help in detecting glaucoma early. Now, aims and objectives to assess the awareness and knowledge about glaucoma in patients coming to the ophthalmology OPD of a tertiary care hospital. Materials and methods. This cross-section study was conducted in the Department of Ophthalmology of a tertiary care hospital. Total 205 subjects. Inclusion criteria, adult patient in the age group of 18 and above. Exclusion criteria, patients who were already clinically diagnosed with glaucoma, patients on any topical anti-glaucoma drugs, patients with predisposing conditions like trauma to the eyeball, uveitis, developmental glaucoma or optic nerve damage. Questionnaire translated to the patient's knowledge was given to all the patients. It included 3 sections. First, demographic data of the patient. Second section, patient's awareness and knowledge about glaucoma. Third section, source of information and if the patient underwent any ocular screening or eye checkup in the past 1 year. The questionnaire was adopted from a similar study done on awareness of glaucoma among residents of North India. The second section pertained to the patient's awareness and knowledge about glaucoma through 10 questions. The initial 4 questions evaluated their awareness and the next 6 questions were used to assess their knowledge of glaucoma. Results. The questionnaire was administered to a total of 205 patients and their answers were analyzed, of which 109 subjects were males and 96 were females. The mean age group of the patients was 49 years. There were statistically significant differences between different age groups and their awareness of glaucoma, yet only 33.9% had accurate knowledge of the disease. Now this is the pie chart which shows the source of information from which patients are getting the awareness of glaucoma. First is hospital, ICAP and health personnel. This is the main important source of information. Second is TV, radio, and newspaper. And third one is family, friends, and relative. Now this bar graph shows the knowledge and awareness of study subjects who had heard the term glaucoma at the time of the study based on the specific questions asked about glaucoma. Some patients think that cataract and glaucoma is the same. Risk of glaucoma increases with age. Anyone can have glaucoma. These were the questions. Conclusions. From the study, it was concluded that there needs to be a strategic plan to increase the knowledge and awareness of the disease, its prognosis, and its management. Since glaucoma usually presents with no symptoms and warning signs until it's too late, spreading awareness and knowledge about the disease is critically important. The emphasis needs to be on the early diagnosis of the disease process, thereby initiating timely management to limit its progression. Thank you.
What was the education status of these patients?
So we have taken everyone, like illiterate and literate also. Like patients who have gone to the hospitals for screening, ocular screening, and patients who doesn't know what is glaucoma, both. Like some patients think that glaucoma, like chitta motia glaucoma and cataract is the same. So we have taken all the patients.
And you showed, I think in somewhere you had written that there was age difference also.
Yes, sir. Like we have taken, sir, people above 18 years, but in different age groups, sir, there was differences were there. It's not statistically significant that different.
Which age group had the maximum awareness?
Sir,
You didn't show that.
50, sir, 49 age.
50 and above.
Yes, sir.
Okay, good.
How do you make sure your patients are well aware of glaucoma? Do you conduct any lectures routinely in the department for the patients and their relatives to make them aware about glaucoma?
Sir.
Because about 41% maximum awareness was from the hospital. Just show that slide. Yeah. 41% was from hospital, ICAP and health personnel. So how did this happen? Was some awareness program, some lectures were conducted by health personnel?
Yes.
Can you elaborate on this 41%?
Yes, sir. So like in eye camps, like in CMC, we conduct the eye camps, like for screening of different disease. Like their patients are coming and we are checking like they have intraocular pressure is high or something is there. So we tell them that about glaucoma, this is the things by that.
Okay.
Thank you, sir.
So do you really get time during the eye camps to make patients aware? I'm sure CMC eye camps are very busy. But what about the relatives? Do you conduct any lectures for the relatives to make them aware about this disease?
Sir, can you, sir, pardon, sir, I didn't.
Some lectures, some public awareness lectures are conducted on glaucoma regularly or during this thing, glaucoma week.
Yes, sir.
When is the glaucoma week?
Sir, like in.
Okay. Sure.
Pankaj Sharma and Dr. Mr. Ansh Sachidevan. You're there? Sorry. Dr. Pankaj Sharma.
Good morning, everybody. I'll be presenting my study on safety and efficacy of alcaftadine 0.25% and olopatadine 0.1% in patients of allergic conjunctivitis. So allergic conjunctivitis, it is a IgE-mediated allergic condition which includes symptoms like redness, tearing of eyes, swelling, and a significant impact on quality of life of patients. So generally, there are a lot of drugs for management of allergic conjunctivitis, but nowadays first-line drugs are dual-action agents, which are antihistaminic and mass stabilizing drugs. So olopatadine is a very well-established drug, whereas alcaftadine is a recently approved drug, 2016. So it has a action on multiple histaminic receptors, H1, H2, and H4. So the rationale behind our study was that alcaftadine has a broader antihistaminic activity, and it has also has anti-inflammatory properties, and many studies have shown that it has faster onset of action. So aims and objectives of this study were that to compare the efficacy and safety of alcaftadine versus olopatadine in patients of allergic conjunctivitis, and to measure change in parameters like TOS, total ocular symptom score, and CHS, conjunctival hyperemia score, and to measure change in quality of life of patients with questionnaires like EPIC, and also to measure the adverse effect and safety profile of the drugs. So this was a prospective, randomized, open label and comparative society study conducted in the Department of Ophthalmology and Pharmacology. Total 110 patients were recruited, divided into two groups, and one group was administered alcaftadine 1 drop daily, and another group was administered 0.1 olopatadine 1 drop twice daily. Follow-up was done on day 15, day 7, 15, and 30. So all patients aged 10 to 60 years of both genders with clinical diagnosis of allergic conjunctivitis, they were recruited in the study, whereas patients with recent ocular infections, recent intake of antihistaminic topical drugs, pregnant or lactating patients, or with increased intraocular pressure, they were excluded from the study. So efficacy was measured with TOS and CHS. Quality of life was measured with a questionnaire called EPIC. Safety was evaluated with adverse effect checklist. Now coming to the demographics, total of 110 patients were recruited. Mean age was 38.8 years. Now coming to TOS. So both drugs, they showed significant reduction in TOS over the follow-up period, but alcaftadine, it showed greater symptom reduction. Coming to CHS, conjunctival hyperemia, both drugs showed significant reduction over the follow-up period, but alcaftadine, it showed significantly greater reduction in the CHS. Now coming to quality of life, eye allergic patient questionnaire. So it included 4 domains: symptom index, daily life index, psychosocial index, and treatment satisfaction index. So both drugs, they showed improvement, but alcaftadine, it showed greater improvement day 15 onwards. So this is the daily life impact index, psychosocial impact, and treatment satisfaction. Now coming to safety evaluation. So both drugs, they showed adverse effects, but olopatadine, it showed more adverse effects. The adverse effects of olopatadine, they were more systemic in nature, like altered taste and headache, but whereas the alcaftadine ADRs, they were mostly local, stinging sensation or burning sensation. Now comparison with causality assessment scales like WHO Uppsala Monitoring Center scales, so they showed that alcaftadine had significantly less severe causality. So now key takeaways from this study. So both agents, they were effective and safe, but alcaftadine, it produced faster and significant symptom reduction, and alcaftadine was also associated with better quality of life outcomes. So strengths and limitations of the study. Ours was the first study to evaluate the safety of the drugs associated with allergic conjunctivitis. Ours was the first study to evaluate the quality of life in patients with allergic conjunctivitis taking alcaftadine and olopatadine. And limitations were that we had a modest sample size, it was a single center study, and just 30 days of follow-up. So in conclusion, Alcaftadine, it demonstrated superior symptom control, greater hyperemia reduction, treatment satisfaction, and better quality of life. And it had a favorable safety profile compared to, these are my references. Thank you.
Dr. Pankaj, you already said that alcaftadine is a well-established drug. So what was the need for doing this study, number one? And do you think 30 days trial or 30 days, clinical trial comparing the symptoms and all that would definitely make a statistical significant study?
So there had been studies which showed that alcaftadine was superior to olopatadine, but there were also studies which showed that it was equally effective as olopatadine, and there hadn't been any quality of life studies. So ours was the first quality of life study.
But I think 30-day study is not going to make the much difference. And another thing is, what is the TOS scoring? How do you score the things on TOS?
So TOS is scored as there are different scores given for tearing, swelling of eyelids, and redness.
How do you grade them? What is the grading?
So 4, 3, 2, 1. Sir,
Which one is severe?
so 4.
You have a patient of allergic conjunctivitis, about a young boy. How are you going to start the treatment? What all drugs will you use besides this thing? Antihistamines, what other drugs will you use?
Sir, other drugs that can be used can be, sir, corticosteroids, sir, or sir, NSAIDs.
NSAIDs.
Sir.
Okay. So what corticosteroids will you use? And for how long?
Sir, in tapering doses, we can use, sir, for a few
Okay.
days.
Okay. What corticosteroids?
So
Okay.
FML, sir.
Thank you. Next is Ans Sachdeva.
Good morning.
Timer, please.
Good morning. The title is Awareness of Diabetic Retinopathy in Diabetic Patients Attending IOPD in a Tertiary Care Hospital in North India. Diabetic retinopathy is a common microvascular consequence of diabetes mellitus, and it is still the largest cause of preventable blindness. Globally, the prevalence of diabetic retinopathy among diabetic patients is estimated to be 27%, and in India it varies from 8.9 to 16.4%. However, in the state of Punjab, the prevalence is much higher than the national average, which is 23.2%. According to the International Diabetic Retinopathy Severity Scale, diabetic retinopathy can be classified as follows: no apparent retinopathy, mild non-proliferative diabetic retinopathy, moderate NPDR, severe NPDR, and PDR. Early diagnosis through regular screening is essential to prevent severe vision loss. People with diabetes should have their eye checked regularly. So the methodology used was, it was a prospective cross-sectional study conducted in the Department of Ophthalmology in Ludhiana, Christian Medical College in Ludhiana, and all the patients from 18 to 75 years of age were included in the study who fulfilled the inclusion criteria. It was a 3-month study, and at the end of each session, the patient were given a pamphlet which would raise awareness of diabetic retinopathy results. The study found that 58% of the participants were aware of the diabetic retinopathy as a possible complication of diabetes. The mean age was 63 plus minus 10 years, and the gender distribution was 46% males and 54% females. 66.9% of the participants reported to have a family history of diabetes, and whereas a total of 55.3% believed that individuals with controlled diabetes could still have ocular complications. Only 37.5% knew that the recommended frequency was every 6 months, and 13.6% believed that annual eye checkup was sufficient. Findings indicate that 52.5% of the participants understood the need for regular eye screening. The majority of the respondents had a positive outlook on the prevention of diabetic retinopathy through effective diabetes management. Less than half of the population had an ocular examination in the past year, indicating a need for improved eye care adherence. Healthcare professionals are the most cited source of information about diabetic retinopathy, accounting for almost 47.4% of the participants. In 60 to 69 years of the cohort age group, it showed the higher level of awareness because of the more frequent healthcare encounters. Participants with family history of diabetes exhibited higher awareness of diabetic retinopathy. This could be attributed to more frequent discussions about diabetic risk among the family members, leading to better informed individuals. The study identified two main barriers of the diabetic retinopathy screening. First was a lack of knowledge, and second was the absence of symptoms. This highlights the importance of raising awareness about the fact that diabetic retinopathy can develop without any noticeable symptoms, emphasizing the need for routine screening. The involvement of healthcare providers in educating the patients about diabetic retinopathy was another noticeable finding. The healthcare professionals play a crucial role in raising awareness about diabetic retinopathy and its complication. There was a limited mass media exposure among the patients, which accounted for almost 10.3%. Boosting the media outreach can increase the awareness and promote preventive care of diabetic retinopathy, especially among those with limited access to healthcare providers. The findings of the study emphasizes that demographic factors such as age, gender, family history of diabetes significantly influence the awareness and the knowledge about the disease. Punjab has a higher incidence of diabetic retinopathy due to a high prevalence of diabetes, poor management, and lack of awareness about the importance of early detection. The region's dietary habits, sedentary lifestyle, and probably high stress among certain individuals contribute to the uncontrolled diabetes and further increasing the risk of the disease. Thank you.
Dr. Ansh, you are doing post-graduation?
I'm a third year student, sir.
Acha.
UG.
Okay.
MBBS student.
MBBS student.
I know उनका जो प्रोजेक्ट होता है
Okay, okay. Good. Yeah. So, what do you think are the measures to be taken to increase the awareness, considering the high incidence of diabetes in Punjab?
So, since the healthcare providers were the major cited source of information, whenever the patient comes to the OPD with diabetes, the patient should be informed about the disease and the importance of early detection through regular screening. And there could be mass media campaigns, like there could be posters everywhere, and whenever the patient comes to the OPD, they could be provided with a pamphlet containing information about the disease and how to control it.
Any relation of the participant with the duration of the diabetes?
Yes, sir. The patients who had a family history and increased duration of diabetes, they are more informed because of the frequent healthcare encounters. They are informed by the healthcare providers about the complication of the disease.
That's right, but the majority who were aware, they were 60 to 69 years of age.
Yes, sir.
So already they were, so how long they were having diabetes that they came to know about the diabetes?
So the average duration was almost 10 to 15 years of the diabetic patients.
Dr. Nirnay Singh? No? Dr. Sangya Yadav? Dr. Sangya Yadav? Dr. Navdeep Kaur? Dr. Navdeep Kaur? Dr. Navneet Dhingra?
Any other participant is there? Dr. Twinkle Gupta is there? Okay. You have loaded your presentation? Okay. You can come in front. And Navreet Kaur is there?
Navreet?
First one.
ये क्या नाम है?
morning. My topic for the presentation today is ocular surface and tear film abnormalities post-cataract surgery, SICS versus phacoemulsification. The tear film is a three-layered sandwich composed of distinct lipid, aqueous and mucin layers. Mean tear film osmolarity is 270 to 315 milliosmoles per liter and pH is 6.8 to 8.2. Incidence of dry eyes is 7.4 to 33.7% of people. Post-cataract surgery, factors contributing to dry eyes are decreased corneal sensation due to surgical incision, which disrupts the corneal lacrimal gland loop, leading to reduced tear secretion, decreased mucin production from the conjunctiva secondary to incision placement, decreased tear film breakup time due to surface irregularities at the site of incision, prolonged use of antibiotic steroid eye drops, poor tear film production and stabilities. Although the symptoms of dry eyes are only transient, they have an impact on the patient's quality of life. SICS causes local injury by severing the larger corneal network of nerve fibers, resulting in corneal hyposensitivity and reduction in reflex secretion and wound healing. This, combined with prolonged intraoperative duration and exposure to microscope, has the potential to exacerbate the symptoms. Phacoemulsification is a contemporary cataract surgery in which the eye's internal lens is emulsified and aspirated from the eye using an ultrasonic hand physics. Incisional denervation of the corneal nerves, ultrasound-induced free radical production, microscope light exposure, time during surgery, and pre- and post-operative medicines have been linked to dry eyes after phacoemulsification. The OSDI, Schirmer test, TBERT are the most commonly used tests for the diagnosis of dry eyes. OSDI is a subjective questionnaire, whereas TBERT and Schirmer's are objective dry eye test. Conjunctival cell abnormalities is diagnosed by impression cytology. So in this study, we have mainly focused on impression cytology. Dry eyes is a known after effect of cataract surgery. So the aim is to evaluate the ocular surface and tear film changes following cataract surgery. Objective is to determine tear film changes, to determine ocular surface changes, and to compare the incidence of dry eyes. It was a randomized controlled trial for 1.5 years and ethical approval was taken. A total of 100 patients were classified into group 1 and group 2. Group 1 undergoing SICS and group 2 undergoing phacoemulsification. Consent was taken. All patients underwent Schirmer's, OSDI, TBERT, and impression cytology. Cytological changes were graded according to the Nelson grading system into grade 0, 1, 2, and 3. Exclusion criteria: pre-existing ocular surface disease, patients already diagnosed with dry eyes, patients with other ocular disorders, contact lens wearers, previous ocular surgery, patients with systemic diseases, and who did not give the consent. Statistical analysis was done, and baseline characteristics in our study, males were slightly more as compared to female in both groups with mean of 61 to 70 years. When the baseline characteristics were compared, they were statistically insignificant. In Schirmer's test at baseline, mean Schirmer test value was 21.74 and 22.26 in group 1 and 2 respectively. After surgery, mean Schirmer value reduced more in group 1 as compared to group 2 at 1 week, 1 month and 3 months with statistically significant difference, though both the groups showed improvement at 3 months, but it never reached the baseline value. TBERT at baseline, mean TBERT value was 12.36 and 12.52 in group 1 and 2 respectively. After surgery, mean TBERT value reduced more in group 1 as compared to group 2 at 1 week, 1 month and 3 months with statistically significant difference, though both the groups showed improvement, but they never reached the baseline value. And when it was compared between both groups, it was found to be significant. OSDI at baseline, mean OSDI value was 10.92 and 11.12 in group 1 and 2 respectively. After surgery, similarly, OSDI value increased more in group 1 and group 2. Impression cytology at baseline, mean impression cytology value was 0.14 and 12 in group 1 and 2 respectively. After surgery, mean impression cytology value increased more in group 1 as compared to group 2 at 1 week and 1 month post-operatively. 3 mean impression cytology value was approximately same in both groups. Increase in impression cytology value was found in both groups after 1 week, 1 month and 3 months of surgery with statistically significant difference. When means impression cytology value was compared between both groups after 1 week, 1 month and 3 months of surgery, it was found to be statistically significant. So as we have discussed, the randomized controlled trial study was done among the 100 patients, and there were changes were found in Schirmer test, TBERT test, OSDI, and impression cytology values. There were certain limitations. Firstly, the corneal sensitivity was not assessed. Secondly, a comparison between postoperative dry eyes and visual acuity was not done in this study. So on concluding, incidence of dry eyes is higher in SICS than phacoemulsification due to tear film instability. To conclude, dry eyes are known to have various etiological factors, out of which cataract surgery is one of the factors predisposing to dry eyes. Eyes with postoperative dry eye may also have lesser visual recovery compared to those who do not develop significant dryness. Further studies with longer duration of follow-up targeted to assess time taken to attain normal status are recommended. Thank you.
What is the cause of dry eye after any cataract surgery? What are the causes?
So firstly, the incision. There is corneal nerve denervation when incision. Then use of topical antibiotics and steroids in such patient. Exposure to microscope is one of the reason. And sir, there is derangement in the goblet cells. Whole of the tear film instability is there.
The phacoemulsification has clear corneal incision.
Yes, sir.
Okay, so the corneal nerves are cut over there.
Yes, sir.
SICS, you make scleral incisions.
Yes, sir.
So where do you think that factor is more? Number one. Rest of the factors are same in SICS. The exposure to antibiotics, steroids, having preservative. Betadine is a very important factor. And you said free radical generation from ultrasound, which is more in phaco. So what is the reason you encountered more dry eye in SICS compared to phacoemulsification? Because according to your theory, phaco should have more.
Sir, firstly, the exposure to microscope light is more in SICS. On the PG level, if we do that.
Not significant. There are people who do SICS in 3 minutes.
Okay.
So I don't think that is the reason. What other?
So then, so mainly the incision is bigger. We are we are taking the flap, conjunctival flap peritomy we are doing. We are disturbing the conjunctiva only. So,
Sure. Okay.
thank you.
Even SICS can be done with 2-3 mm.
Yes,
incision.
sir.
What is the clinical significance of this paper? What is the clinical significance of this paper? Where do you imply this?
Sir, to treat patients with dry eyes post cataract surgery means how prolonged duration we need to treat them. Like till 3 months, it will become, it will never reach the baseline, but it will come to a good standards so that.
So do you recommend using lubricants in all your post-cataract patients, whether SICS and phaco, and how long?
Sir, if it is disrupting their life, yes. If they are complaining of foreign body sensation, and yes, I would recommend.
Okay.
Thank you.
Let's say Dr. Twinkle Gupta.
A very good morning to one and all present here. I am Dr. Twinkle Gupta from GGS-MCH, and I will be presenting my paper on awareness about incidents about body fluid splash injuries to eye and protective eyewear practices in healthcare workers. So healthcare workers are at an elevated risk of exposure to life-threatening infections like HIV, HBV, and HCV. While hand hygiene and PPE are always in the limelight, eye protection always takes a back seat. So our aims and objectives include to assess the awareness of doctors about the risk of bloodborne pathogen transmission through eye splash injuries. Secondly, to assess the knowledge and protective eyewear and identify the barriers in their use. So we made a 29 MCQ questionnaire with a lot of visual cues, and we distributed it through online survey, through WhatsApp, and printed, which we distributed in the OPDs. So in our study tool, the 29 questions were divided into 4 categories: demographic details about medical specialty and years of experience, incident history about history of blood splash injury, procedure it was done, and viral markers of the patient, awareness about bloodborne pathogen transmission, universal precaution and use of PPE glasses, along with safety precautions about steps after blood splash injury, and facts about protective glasses. So Total 137 participants were included in the study, out of which 35% had a history of blood splash injury, out of which a staggering 6.3% had a history of incidents of blood splash injury, which are HIV, HBV, or HCV positive patient. So in our demographic details, maximum of the doctors included had less than 10 years of experience, maximum were from ophthalmology, followed by pathology and ENT. 71% of incidents were seen during emergency surgeries. These surgeries were generally less than 1 hour. The most common procedure experiencing such incidents was C-section followed by emergency suturing. So about awareness, the third section. 46% of the doctors did not know that 1/3 of Hep C exposures are through mucocutaneous routes. 27% were unaware that there have been documented cases of HIV and Hep C transmission through conjunctival blood splash injury. Majority were unaware that there is a 45% incidence of blood splash injury to eye even while wearing protective glasses. 48.9% did not know that even wearing prescription glasses does not eliminate the risk of blood splash injury to eye. So precautions. 41% said that they routinely wear eyewear, but the rest who did not, they cited a few reasons, out of which the most common one was fogging, followed by discomfort, and third one, routine unavailability. So at the end of the survey, we had, after telling the doctors about the awareness and the PPEs, we asked them, are they willing to wear the protective glasses now? We saw a staggering increase. Initially, there were 41% who were willing to wear. After the survey, there were 72% doctors who were willing to wear. So a 31.2% increase was seen after only a survey. The salient features of this study was we could assess the impact by documenting a 32% increase. Similar studies have been done by Chong et al., where out of 71 participants, 22% had experience of blood splash injuries. Davies et al. Had 384 operations, out of which 45% had such incidences. And Olabisi et al. Did 144 cases of C-section, out of which 63% had blood splash injuries on the surgeon goggles, and 38% had blood splash injuries on the assistant goggles. So the strengths of my study, it's a mixed approach study. So we went for OPD and WhatsApp. Survey addressed knowledge, behavior, and barriers. Impact was assessed at the end of the survey. The limitation was it was a smaller sample size, hence limited generalizability. And self-reported data was seen, hence there was a major recall bias. Future direction, we can target some educational programs regarding the same and collaborate with healthcare facilities to ensure there is availability and accessibility. Hence, there is a need to increase the awareness and compliance with protective eyewear for healthcare workers to reduce the transmission of blood-borne pathogens through eye splash injuries. Thank you.
Any segregation of this department-wise? Suppose you took 100.
Yes, sir, I have, sir.
Yeah, and out of that, 70 were from gynae department. So how that could have influenced your study?
Yes, sir, 100% it could have been. So even there were two problems in this. First, I only know doctors who had less than 10 years of experience. And second, maximum people I know were from ophthalmology and ENT. But in the studies, it has been reported that there is a higher incidence in vascular surgeries and C-sections. So
right.
That could, we need a bigger sample size for that.
But of course, specialty of the
Yes,
participant did matter.
Yes, sir.
And have you ever yourself encountered such?
Yes, sir, multiple, sir. That's why I did this, sir. So there was 1 month in which there was a ENT HOD, sir. One of my co-residents who had a blood splash injury with an HIV patient. So she had to be on ART for 1 month, after which I had started.
So what is the immediate treatment?
So a wash, 1 to 2 liter NS RL wash.
Is it simple tap wash or some kind of the other tap is there?
So we generally use the RL bottle, we put it on the IV stand, put IV line, and we just put a kidney tray and do the wash.
Go what the NABH recommends for
Okay.
that. There is a special tap, there is a container, and the pressure comes with 2 tap, and
Okay,
you have to wash it there only with the pressure.
Okay, sir.
Go and read in NABH.
Okay, sir. Thank you, sir.
What is the incidence of these viral infections, HIV, hepatitis B or HCV after splash of
Sir,
blood and body fluids?
so there's not such incidents, but there have been documented cases. There is no study which is saying this is the incidence of HIV through blood splash injuries, but I have seen there were 2 documented cases of one of HIV and one of HCV.
You mean there is no published literature on this? I don't believe this.
So when
There must be.
There is.
So when I had
Have you done review of literature?
Yes, sir. Yes, sir. So when
So if you are not aware of the incidence, then what makes you say that it is because of the this thing contact with mucocutaneous? Normally it is the prick, small needle prick injuries which lead to accidental needle prick injuries during surgery.
So all the point that had said that 1/3 of Hep C exposure are through mucocutaneous. So I've taken references for all of these. I've taken them from proper studies, sir.
From published.
Yes,
That means
sir.
there has to be incidence.
Yes, sir. Yes. So,
If
but
it is
there
a
is not,
report-
sir. There's not specific or only blood splash
You
to
didn't.
conjunctiva.
I don't think you
couldn't
did
find.
a review of literature properly.
Maybe,
Incidence
sir.
has to be there.
Maybe, sir.
Okay.
Yes, sir.
Thank you.
Thank you, sir.
Next is Dr. Navreet Kaur. ढीला है क्या सिस्टम?
Can audiovisual help?
Yeah.
Good morning, everyone. So my topic is to evaluate the serum VEGF level and its association with genetic mutation in VEGF gene in patients with and without diabetic retinopathy. So aim of my study is to evaluate the serum VEGF level and its association with genetic mutation in VEGF gene in patients with and without diabetic retinopathy. So objective is to evaluate the serum VEGF level and single nucleotide polymorphism in VEGF gene in diabetic subjects with and without diabetic retinopathy, and to check the association between VEGF serum level and single nucleotide polymorphism in VEGF gene in diabetic subjects with and without diabetic retinopathy. So there were two study groups. One group they were diabetic patients without diabetic retinopathy, and second group was diabetic patient with diabetic retinopathy, which was further divided into mild, moderate, severe, and PDR group. So it was our work outline. Identification of the specific subjects was there. Uncorrected visual acuity, best corrected visual acuity was done, and detailed slit lamp examination and dilated fundus examination by indirect ophthalmoscope was done. Diabetic status was estimated by HbA1c, and VEGF A protein level was estimated by serum VEGF A by ELISA, and VEGF gene mutation was done by PCR, and statistic analysis was done, and this was our master chart. So results were like first chart is of fasting blood sugar level. There were mild, there were 7% increase, and moderate there was 21% increase. In severe there was 41% increase, and in PDR there was 72% increase in FPS, and in RBS there was mild 20% increase, and moderate there was 32% increase, severe there was 66% increase, and proliferative there was 80% increase in RBS. In HbA1c level, in mild there were 4% increase, in moderate 14%, severe 21%, and PDR 39% of increase in HbA1c level if we compare it with the non-diabetic retinopathy group. So in VEGF, serum VEGF level, in mild there was 33% increase, in moderate there was 56% increase, in severe there was 1-fold increase, and in PDR there was 1.5-fold increase in HbA1 in VEGF level if we see with the non-diabetic retinopathy group. So this was the genotyping of VEGF gene. There were two bands, that is homozygous. If there were one band, and if two bands there was insertion or deletion, that is heterozygous was there. So these were genotyping results. So in moderate and severe there were two bands was observed. In PDR group there was only one band observed, which is that there is homozygosity, that is there is severe condition if as it expressed in the higher rates. There will be VEGF upregulation and increase in VEGF protein, that is also mentioned in literature, that is DD overexpression is associated with severity of DR.
So Hardy-Wing equilibrium analysis was done. I allele was 22 and D allele was 108. So this was our graph, which was expected. And so conclusion is serum VEGF level is found to be higher in diabetic patients. VEGF level increased as the severity of DR increases, and PDR had the highest VEGF levels. So measuring the serum VEGF can help in early detection, staging and monitoring of DR. Serum VEGF has the potential to be used as predictive biomarker for DR. Thank you.
Yeah, Navreet, I think it's a known fact that VEGF level are increased in diabetic retinopathy. Your title was to show the association with genetic mutation, but in conclusion you did not mention anything about association of VEGF level and genetic. Can you go to the conclusion slide?
Sir, actually we have done only 65.
Can you show the conclusion slide, please?
Yes.
Go back.
Sir, I have
Yeah.
opened it. So we have done, at now, we have done only 65 samples. So till now it's significant, it is correlating with the serum VEGF level, and there is mutation in VEGF gene. And wherever this VEGF level was increased, there is mutation in genotyping. But other samples are still under process. So till now it is a significant.
But the title, what you said, title of the paper, there's nothing about that title in the conclusion. Na? These are all known facts. So what your paper adds to the already existing knowledge?
Sir, serum VEGF level, if we do that ELISA of the serum VEGF level, so we can early detect the DR. And also mutation is there in the VEGF gene. Sir, I haven't mentioned in this, sorry
Okay.
for that.
Okay, thank you.
Is there any difference between serum level of the VEGF or plasma level of the VEGF? Or both are same?
Sir, it was same. Serum, it was same.
Same. So I think with that we conclude this session. Any other presenter?
You're there?
You're there? We called you many times.
What's your name?
Navdeep. Okay, lens excision.
Come fast.
Chalo.
Any other presenter?
Slides, please.
Good morning, everyone. My study is to study the risk factors and effects of early lens extraction on IOP, ACD, and lens positioning in eyes with occludable angle. My moderator is Dr. Rajvinder Kaur. Magnitude of the problem, it is estimated that prevalence of angle closure glaucoma is 0.6% globally with 0.7% in Asia alone. Acute attack of angle closure glaucoma represents only the tip of iceberg, as predominant form of angle closure glaucoma is chronic and asymptomatic. The coexisting angle crowding and pupillary block are the most important mechanisms responsible for angle closure, and lens plays a pivotal role in this. A clinical hallmark of eyes, smaller or hypermetropic eyes, shallow AC, increased lens thickness of more than 4.40, and anterior lens positioning, that is relative lens position factor. The landmark EAGLE study also proved that IOP control post-phacoemulsification is superior to laser iridotomy. It not only corrects the anatomical predisposition to the angle closure, not only deepens the AC but also opens the angle, improving the diurnal IOP variation. Lens axial length factor was calculated. It is a ratio of lens thickness to axial length, and it is more relevant than lens thickness alone because it explains why age-related increase in lens thickness leads to angle closure in small and hyperopic eyes. Mean is 1.91, and increased laugh is a risk factor for angle closure glaucoma. Relative lens position factor is indicative of position of lens in the eye. It explains that myopia can have angle closure if the lens is placed anteriorly. It was calculated by ACD plus half of the lens thickness divided by 10 divided by axial length into 10. More than 0.23 is normal. If decreased, it indicates anterior lens positioning. Aim of the study was to study the risk factors and effects of cataract surgery on IOP, ACD and lens position. Objectives were to assess the various risk factors in the eyes, to correlate the changes in ACD and IOP after cataract extraction, and to correlate delta GAT with LAF after the cataract extraction. It was a cross-sectional analytical study. 50 eyes of 25 patients with occludable angle were taken. The patients were having von Harry grade less than 2 and vision was 6/9 on a Snellen chart or less with early cataractus changes were included in the study. The patient with glucomatous optic disc and optic nerve disease were excluded. It was a hospital-based cross-sectional study. 50 eyes of 25 patients underwent detailed ophthalmic evaluation. Corrected GAT was done, gonioscopy was done, and all the patients were screened for glaucoma. These were taken by IOL master, and 30 eyes among 50 eyes had underwent phacoemulsification. So these were the results. 80% of our patients were female and 90% of them belonged to cataractus age group. 26% of the population had axial hypermetropia. Lens thickness more than 4.5 was a risk factor, and in the study 52% of eyes had lens thickness more than 4.5. LAF is a unifying unit to define the relationship between lens, iris and cornea. It is age dependent with a mean normal value of 1.91. 47% eyes or 94% of our patient which has a hallmark of anteriorly placed lens. This was the master chart. All the data was calculated. A positive correlation was found between change in post-op IOP and depth of anterior chamber after cataract surgery. And a positive correlation was found between change in IOP and lens axial length factor. And to conclude, a hypermetropic eye with increasing lens thickness is an angle closure glaucoma in the making. Apart from lens thickness, ACD and axial length, newer biometric measurements like lens axial factor and relative lens position factor have proved to be important diagnostic tool. Increased lens thickness accounts for 0.35 mm of AC shallowing, and forward lens position accounts for 0.65 mm of shallowing, and together they cause 1 mm decrease in ACD. So take-home message is that phacoemulsification, we should suggest phacoemulsification for patients with occludable angle and early cataractus changes, as it permanently resolves the anatomical predisposition to angle closure in these eyes. Thank you.
You calculated lens factor and relative lens position, both before and after surgery? You didn't show anything after the surgery, did you?
Sir, it was not shown in this, but lens thickness was calculated after the cataract surgery. Positioning was not calculated after the surgery.
You showed that slide?
No, sir, that
where
is not
parameters
No, she has not done.
you have not done it.
shown. No, sir.
How come the
See,
title
your study and your title has to match. Na? You study the risk factors and effects of early lens extraction.
Yes.
Your conclusion shows that after phacoemulsification, there is increase in anterior chamber depth, decrease in intraocular pressure, but there's nothing in the study.
Yes, sir.
Okay?
Lens positioning was not studied post-op.
Okay,
sir.
okay. Thank you.
Thank you, sir.
उसी का है वो है ना ना ये राजेंद्र गौर की तो बिल्कुल है. I think that concludes. Thank you very much.
We'll have a group photo with all the presenters. So we hand over the session to the next panel. Before that, can I invite all the presenters to come for a quick group photo?